So starting with directional preference, this was discussed briefly at the end of the assessment there, once we kind of did some provocative testing and we're at a point where the system might be a little bit sensitive. We're seeing, hey, can we actually calm the symptoms down with a particular repetitive direction of the spine in this case. You can do it with other joints, but the spine will be relevant to the lumbar spine specifically, will be relevant for this case we're discussing today. So just a general background, directional preference is a direction that will decrease symptoms. Most specifically, if there are distal symptoms, we're looking for a phenomenon called centralization, where the distal symptoms will decrease, and there even might be a increase in proximal discomfort, maybe some local achiness at the low back. This is an important note to communicate with the patient. Hey, this is something you might experience, but it's okay. We're going to keep going. That's a sign that we are getting the outcome that we want. So when it comes to directional preference or McKenzie repetitive in-range loading, the directional preference within that system of MDT indicates that there is a derangement syndrome is what they classify it as. So a derangement has a directional preference. It is highly variable and, with presentation, with time. So these are factors that you can keep in mind when hearing the history and saying, hey, maybe they might be a responder to a particular direction. And you could do sustained or repetitive. I like repetitive and range loading. And I have a little infographic in the slides here if you did want to look at it as a reference and maybe to learn some more about potential mechanisms that are occurring with repetitive and range loading. Again, it's cool to nerd out about the potential mechanisms at play, but again, we're going to focus on the outcomes, what the symptom and functional response is to our repetitive loading. So when it comes to the mechanisms, I'm going to give a quick little spiel about 4 potential mechanisms that could be occurring with repetitive in-range loading. Number 1 is the disc theory, which used to be taught by MDT. The disc theory actually proposes that there is a migration of the nuclear material within the disc, and this would assume that the nucleus pulposus is causing sensitivity, whether at the outer annulus or interference at the nerve root level. And the extension, for example, if that's the direction that we're talking about, is closing the wedge per se, where the bulge is, and moving the nuclear material anteriorly away from the sensitive structures. So that's potential mechanism 1. Again, it's a hit or miss in the literature whether that is actually occurring. Many studies do not actually show that that's actually occurring. Some do. I'm just presenting you with potential mechanisms for a intellectual conversation here. Mechanism 2 would be stimulation of mechanoreceptors in the joint capsule themselves. So when we're talking about the joint capsule, there are mechanoreceptors, chiefly the type 3 mechanoreceptors that respond to and range, but they're also high threshold. And what this means is that they respond to a quick or high velocity force or a high volume of stimulation. So this could be the repetitive in-range loading where you're getting high volume, or this could be something like a chiropractic adjustment where you're getting that stimulus really quickly at in range to have input to these mechanoreceptors, which actually have an analgesic effect and can help the individual feel better. This can also increase range of motion at any restricted segments. And if this is a derangement classification that actually responds to directional preference, then that could explain why there's potential improvement with functional outcomes as well, with increasing range of motion there. 3 is actual pooling of blood in the vasonervorum. So this would cause ischemic compression and irritation at the nerve root level. And the idea is that this could be caused, again, by some sort of hang up in the interface where the nerve root is exiting, whether it be, a disc herniation, something along those lines, causing compression and decreasing the ability of the blood to move through the vessels that are in the epineurium itself. So to give you some more background, in the epineurium, or the tissue that's around a peripheral nerve, that's nerve root all the way to the periphery, there are blood vessels and nerves that supply the nerve itself. So the pooling of blood in the vasonervorum has a stagnation effect and an ischemic compression effect that causes sensitivity to the nervi nervorum, which act as mechanoreceptors that produce a nociceptive pathway when there is stimulation of those mechanoreceptors or the nervi nervorum, which is the nerves that are in the epineurium. Potential mechanism number 4 would be a neurophysiological modulation, and this gets into the central sensitization conversation where there is maybe some fear avoidance or like red flags that the brain is sending, causing an actual like pain experience. And so what could potentially be happening is someone's engaging again with the example of extension, passive extension. That is a movement that is not causing pain. It's a movement that's actually decreasing pain. So they're actively getting a positive experience to that repetitive motion, which has almost like a calming effect from the central nervous system standpoint. Brain's telling the body, hey, everything's okay here. So kind of decreasing the threat level. So that's just another proposed mechanism of, hey, why is this directional preference stuff actually helping out? So realistically, all 4 of these could be occurring at the same time.